So we'll start our session with the BCQs, right? One more thing, it's an interactive session, so I like everyone to be just participate in it, just write it down the answers. I have explanation as well, but I want you guys to answer it along the questions. Okay, it's an interactive session totally. So you have to write it down your answers. That will make your concepts more crystal clear. So we are starting with the first question. 48-year-old woman developed constipation of magnesia. That is the magnesium. She presents to your clinic at which time her serum electrolytes are checked and she is noted to have an elevated serum magnesium level. So which of the following represents the earliest clinical indication of hypermagnesia? Anyone? Okay. I guess most of you give the right answer. The earliest clinical indication of hypermagnesia is loss of deep tendon reflexes because she is already given the milk of magnesia as it is stated in the question. The states of magnesium excess are characterized by numerous neuromuscular generalized depression. MGSO4 is administered until depression of the tendon deep reflexes is observed, a deficit that occur with modest hypermagnesia. So greater elevation of magnesium produce progressive muscle weakness, which culminates in placid quadriplegia as well. And in some cases, respiratory arrest due to paralysis of the chest below mechanism as well. So this is just because the patient already took the milk of magnesia and they are asking you that what is the sign and symptoms of hypermagnesia. So in this way, you know that it is the loss of deep tendon reflexes, right? Proceeding to our next question, following a surgery, patient develop oliguria. You believe the oliguria is due to hypovolemia, but you seek cooperative data before increasing intravenous IV fluids. Which of the following values support the diagnosis of hypovolemia? Anyone? I guess most of you give the right answer. So it's the fractional excretion of sodium that is calculated as urinary sodium. You have to multiply with serum cred, divided with the sodium and urinary cred and multiply by 100, right? So if it is less than 1, supports a pre-renal etiology for the patient's oliguria. Okay, when oliguria occur post-operatively, it is important to differentiate between low urine output caused by physiologic response to intravascular hypovolemia and that is caused by acute tubular necrosis. So if it is less than 1, then it is probably due to intravascular hypovolemia, right? But if it is more than 1, then it is a sign of that it is acute tubular necrosis. So in this way, you have to remember that what of the value, like if it is less than 1, it is indicating the intravascular hypovolemia. But if it is more than 1, then it is probably indicating the acute tubular necrosis. Sometimes they can ask you the way, like what is the value, like less than one and more than one, and sometimes they will ask you to, they will give you just 2%, and they will ask you what is the cause of acute tubular necrosis. So in this way, you have to see that either you have done any type of foreign body procedure, are you placing any stent, are you placing any type of mesh, or anything that causes a reactive reaction. Yes, doctor, you can see the question. So you need to see it. But most of the time, post-operatively, you have to give the fluids just to maintain the BP of the patient, just to maintain the hemodynamic condition of the patient. So that can also causes the intravascular hypovolemia. So to see the what is the reason of that, you have to see the fractional excretion of sodium, that is the less than one, and if it is more than one, then it is probably signs towards the acute tubular injury. Now come to the next question, that an 18-year-old previously healthy man is placed on IV heparin after having a pulmonary embolism after expiratory laparotomy for a small bowel injury following a motor vehicle collision. So 5 days later, his platelet count is 90,000 and continued to fall over the next several days. The patient's serum is positive for antibodies to the heparin platelet factor complexes. So which of the following is most appropriate next step? Anybody? Let's everybody answer it, because whatever in your mind, you have to clear it, right? So just make sure you possibly as much as participate as you can. Okay, so the answer is D. The patient has heparin-induced thrombocytopenia, which is a complication of heparin, because that patient is already on heparin, right? At both prophylactic and therapeutic dose, heparin-induced thrombocytopenia is mediated by antibodies to the complexes formed by the binding of heparin to the platelet factor 4. So in previously unexposed patient, HIT, or we can say heparin-induced thrombocytopenia, typically manifested after 5 days as a decrease in platelet count by 50% of the highest preceding value to a lesser than the 100. For example, if it is 90, if it is 80, even after 5 days, it can be decreased by the 50%, right? So complication of heparin-induced thrombocytopenia will be related to can be arterial, can be venous thromboembolic phenomena, and treatment of consists of cessation of heparin. The first thing is that whatever the drug is trying to harm you, you have to cease that drug. If you are just giving the protamine sulfate, lupridine or something, and you are not stopping the drug, you are just going with the a vicious cycle, right? Because including low molecular weight, weight heparins, institute of a non-heparin anticoagulant such as direct thrombin inhibitors, including lepridine and agratobin, and conversion to oral warfarin when appropriately reach the levels, right? So cessation of heparin alone is inadequate to prevent thromboembolic complications, and warfarin should not be started until the platelet count is above 100, because if you started it, so there will be the hematoma formation as well for the warfarin therapy as well. So it will be a more when we try it. Platelet transfusion is not indicated as heparin-induced thrombocytopenia result in thrombotic rather than hemorrhagic complication. That's why we are not even infusing the platelet right away. Getting the point? So far, so good. The first thing is you need to seize it, and the second thing is you need to introduce a low molecular weight heparin to maintain the hemodynamic stability of the patient. Because if you seize everything, that patient will also go into the vein, right? So you have to maintain the balance. If you are just stopping the one, you have to maintain with the another one, but don't go with the warfarin, because it is also causes the complication as well. So another question is 78-year-old man with a history of coronary artery disease and an asymptomatic reducible inguinal hernia request an elective hernia repair. So which of the following would be a valid reason for delaying the surgical procedure? Doctor, either you are giving the heparin or warfarin IM, either you are giving with the IV, the mechanism will be the same. IV have a fastest thing to just go in the body, and IM will be go with the slow. So these two drugs you have to avoid, and you have to just go with the low molecular weight heparin. That is, the will be the ergobatin as well, and also the lipridin. Okay, this question is kind of tricky. They are asking you which of the following would be a valid reason for delaying the proposed surgery. Just see the all of the options once again. Coronary artery bypass, if 3 months pass and it is successful, that is not a problem. You are just going with a valid reason, right? History of cigarette smoking have nothing to do over here. Even if you are a chronic smoker and you are going to the surgery, it is having an protective effect. And you stop the cessation of smoking before the operation, it is more having harmful effect. Okay, those people who answer C is the right answer. So according to the Goldman and other has guideline has served to identify risk factor for preoperative myocardial infarction. The highest likelihood is associated with recent myocardial infarction, right? So evidence of congestive heart failure such as jugular venous distension, S3 gallop also carries a higher risk as does the frequent occurrence of atopic B. Older patient greater than 70 years and emergency surgery are risk factor independent of these. Coronary revascularization by coronary artery bypass tend to protect against myocardial infarction. So that is the protective factor, just like as the cigarette smoking. The only worrisome factor over here will be the jugular venous distension that will causing the S3 gallop, that will causing the we can say hepatic impairment as well. So there will be a more harm over there, and the patient can go into the congestive heart failure as well. So this is the valid reason you are delaying the proposed or proceeding surgery. Hyperlipidemia, hypertension, I guess in 90 or 80% population, everybody have. So this is not the valid reason. Coronary bypass, it's already successfully done, so it is not the reason as well. Only reason left will be the jugular venous distension. Smoking, diabetes, hypertension, hyperlipidemia are surprisingly not independent risk factor, although they may increase the death rate should an infarct occur. The value of this information and data derived from further testing is that it identifies a patient who needs to be monitored invasively with a systemic arterial catheter and pulmonary catheter, right? So we are proceeding with new question. A cirrhotic patient with abnormal coagulation studies due to hepatic synthetic dysfunction requires an urgent cholecystectomy. A transfusion of FFP is planned to minimize the risk of bleeding due to surgery. So what is the optimal timing of this transfusion? Doctor, why in the recovery room? It's basically on call of the surgery. Recovery room is when you just take out the patient and you are putting in the recovery room just for the sake of seeing any post-operative complication, right? So transfusion with FFP to replenish vitamin K dependent clotting factors should be administered on the call to the operating room. The timing of the transfusion depending on the quality of each factor drive and its half-life. The half-life of most suitable factors, like factor 7, is 4 to 6 hours. Thus, transfusion of platelets on call to the operating room ensures the transfusion is complete prior to the incision with circulating factors to cover the operative and immediate post-operative period. If you are doing on table while you open the patient, it is no use because you are doing the blood loss at the same time and you are transfusing it, so it is not making any difference. If you are doing it after it, the blood loss is already half done, so there's a much risk of die with the shock due to the hypovolemia, right? But if you are transfusing it prior to the table, like you just shift the patient and you are just transfusing it and then you open before the incision, that will be more beneficial for the sake and for the life of the human. Okay, on post-operative day 5th, an otherwise healthy 55-year-old male recovering from a partially hepatectomy is noted to have a fever of 38 degrees centigrade. Which of the following is the most common nosocomial infection post-operatively? Are you all sure that wound infection will be the most common nosocomial infection post-operatively? It's C basically. Urine tract infection is the most common nosocomial infection just because of that catheter. The treatment consists of removal of an indwelling catheter as soon as possible and antibiotic therapy for culture with greater level of 100,000. That will be more possible because every patient who is going to surgery have a urinary catheter, right? That urinary catheter causing the urinary infection. Wound infection will be the complication even after the 5 or 4 days. Immediate always complication will be the hemorrhage. Immediate complication will always be the we can say sepsis. Immediate complication we can also say the atelectasis. Urinary catheter can causes infection, but wound infection can be developed even after to 5 or 6 days when there is a serous inguinal discharge from the wound, or there will be the opening in the wound, or there will be the sinus formation in the wound, or there will be the fistula formation in the wound. So this will be the not the most common infection, right? Pneumonias, wound infection, intra-abdominal abscess, catheter blood stream infection also causes nosocomial infection. And a workup of post-operative fever should be include carefully examination of the patient and other diagnostic tests such as chest X-ray, blood culture, and CT scan to rule out either there is any bleeding going on secondary to the operation or something. Okay, now again, new question. 10 days after expiratory laparotomy and lysis of addition, a patient who previously underwent a low anterior resection for rectal cancer followed by postoperative chemoradiation is noted to have a sequence draining from the wound. She appears to have adequate source control. She is febrile with a normal TLC count. The urinary output fistula is approximately 150 cc per day. Which of the following factors is most likely to prevent closure of the enterocutaneous fistula? Anybody? It's basically, just see the question. They are asking you that what is the most likely factor to prevent the closure of enterocutaneous fistula? This is because of the radiation. Factors that predispose to fistula formation and may prevent closure include foreign body, any radiation, any inflammation, epithelialization, new plasma, distal obstruction, and steroids. Anything that can obstruct the pathway of the fistula can prevent the fistula formation to be closed, right? So you have to remember from this friend's mnemonic, like number one will be the foreign body, number two, radiation, inflammation, reepithelialization, neoplasm, and distal obstruction. Factors that result in unhealthy or abnormal tissues surrounding the enterocutaneous fistula decreases the likelihood of a spontaneous resolution. So if it is any foreign body over there, it will prevent the closure of fistula. If there will be a radiation you are giving directly, it will be responsible for this. Sir, how can surgery be a reason of prevention? Because after even surgery, there will be a fistula formation or something because it's a complication of surgery, right? So it cannot be the prevention for the closure. Any inflammation, like if there is any bacteria, any foreign body, any ongoing infection is going on, that will also causes it to prevent from the closure. Any epithelialization means there is new growth factors are growing, new type of vessels are growing, there is a new type of tissue is already made, so it cannot be close the fistula as well. Any type of mass, any type of obstruction, any type of steroidal medication, because steroid can also decrease your immunity, so it will also prone more likely to the infection side. And whenever there's an infection, there will be the inflammation. So the vicious cycle is going on. So the only answer over here will be the radiations. Radiation therapy such as treatment of pelvic, gynecological, and rectal malignancies can result in chronic injury to the small intestine characterized by fibrosis and poor wound healing. High output fistulas, such as those with more than 500 cc per day output, are usually proximal and unlikely to close. Treatment consists of source control, nutritional supplements, wound care, and delayed surgical intervention if the fistula fails to close. Right? These are the things. Even if the having person who is having a high diabetes, uncontrollable diabetes is also the reason as well. And who is not even taking the nourishment as well is also the reason. Okay, so 26-year-old man is resuscitated with packed red blood cells following a motor vehicle collision complicated by a fracture pelvis and resultant hemorrhage. A few hours later, the patient became hypotensive with a normal CVP, oligouric, and febrile. Upon examination, the patient is noted to have profuse oozing of blood from his IV site. One thing in this question is the patient is having pelvic fracture. Another thing is that profuse oozing from the blood from IV side. So which of the following is most likely diagnosis? Anybody? I give a two in the question. One is the profuse bleeding from IV side and another will be the pelvic fracture. And they are asking you the what is the most likely diagnosis over here. So let's see the answers. Okay, let me turn up the question. Now you can see it. Now these are the answers. Okay, so D will be the answer. That is, this patient died from the transfusion reaction, not from the hypovolemia. This patient died from the transfusion reaction. Transfusion reaction can be categorized into hemolytic versus allergic non-hemolytic reactions. So hemolytic transfusion reactions are caused by complement mediated destruction of transfused red blood cells by the recipient's pre-existing antibiotics. Severe hemolytic transfusion reactions usually involve the transfusion of ABO incompatible blood with fatalities occurring 1 in 6 lakhs unit. Do you see this question again? That this was resuscitated with red blood peg cells, right? And having a pelvic fracture as well. And having a pelvic fracture cannot be put the patient on the febrile state. Can be put on the state of tachycardia, can be put on the state of hypovolemia because it's a pelvic fracture and there will be a 600 to we can say 1000 ml blood loss at a time. But the signs of hypovolemia will be like tachycardia, will be like paleness, will be like cold peripheries, but there is a febrile illness. Any type of pelvic fracture cannot be caused febrile illness up right away. This patient put on the transfusion, and just because of the transfusion reaction, the patient get febrile. So this is the transfusion reaction because whenever there's a transfusion reaction, there's a shivering, there's a pain, there's a drop in BP as well. So this is the reason peptides from the complement release in the blood as the red blood cells are rapidly destroyed, causing hypertension, activate coagulation, and lead to GIC. That's why the fever was over there. So symptoms of a hemolytic transfusion reaction include fever, chills, pain, redness along the infused vein oozing from IV side, respiratory distress, anxiety, hypotension, and oliguria. The patient would have a low CVP with hypovolemic shock, acute adrenal insufficiency, gram-negative bacteremia, and urethral obstruction would not causing oozing from the IV side. These are the reason that this patient developed because the patient from the transfusion reaction went in the DIC, and in the DIC the patient got bleed. With the bleed, the cascade will be reactivated, and that causes the inflammation, the fever, all of these signs. That's why I said in the start, the surgeries, BCQs are kind of a bit tricky. So a 16-year-old girl, adolescent boy with a history of a severe hemophilia A is undergoing an elective herniorrhaphy repair. So which of the following is the best option for the prevent or treating a bleeding complication in the setting of this disease? Anybody? Also, it is, they already mentioned that it is hemophilia A, right? So what we are giving the T option, that is the combination of aminocarpuric acid and desmopressin. Hemophilia A is a coagulation disorder resulting from a deficiency or abnormality of factor VIII. Desmopressin is a synthetic analog of antidiuretic hormone that increases the level of factor VIII and von Willebrand factor. That is, DDBAP can be used alone for mild hemophilia A, but is ineffective, right? In severe forms of the disease. Fresh frozen plasma we cannot give in that state, doctor. We will be give the desmopressin along with the aminocarpuric acid. You see the question? If we can say that a patient is go in a vein like there's a knee bleed, or we can say there is a any joint that can be bleed, that will be a severe form. Then for the in severity, to control the severity, we will give the FFP. But over here is desmopressin and aminocarpuric acid will be the good answer over here. For severe hemophilia A, DBP is given in combination with an inhibitor of fibrinolysis such as aminocarpuric acid. As I told you, although FFP contains factor 8, the levels are too low to prevent or control bleeding in hemophilics. This is also the reason. And other agents used in the treatment of hemophilia A include the cryoprecipitate and factor 8 concentrates. If aminocarpuric is not an answer, you have to select the cryoprecipitate and factor 8, because the FFP have the low count, or we can say low concentration, to prevent the bleeding control in hemophilics. And this patient is already diagnosed in the start of hemophilia A. Okay, so a 59-year-old man is planning to undergo a coronary artery bypass. He has osteoarthritis and consumes NSAID for the pain. Which of the following is the most appropriate treatment prior to surgery to minimize his risk of bleeding from his NSAID use? Anybody? These type of questions are more likely to ask an exam that how much prior to surgery you are stopping the medications. You will see the surgery portion and you will find there are couples 4 to 5 questions from this, that when you are stopping any anticoagulant, any type of medication before surgery, if a patient is already having a high risk or a patient is already having any comorbids. Okay, most of you give the answer C, right? And half of the people gave the answer D. So let's see. It's basically the D, because NSAIDs such as aspirin block platelet function by causing a reversible defect in enzyme cyclooxygenase. Unlike aspirin, which permanently acetylate oxychlooxygenase and leave affected platelets dysfunction throughout their 7-day lifespan. So NSAIDs causing a reversible defect that lasts 3 to 4 days. Therefore, the patient's platelet will be functional for surgery if he stopped taking NSAIDs 3 to 4 days prior to the date of surgery. The patient would not benefit from FFP or vitamin K since he does not have problems with his clotting factors. So the over here will be the D. You have to stop only 3 to 4 days, because this patient is not having any type of bleeding disorder, right? If it is having any bleeding disorder, then we will think about more prolonged duration, like 1 week prior, 2 week prior. If it is having hemophilia, if it is having von Willebrand disease, if it is having thrombocytopenia, if the person is having any type of bleeding disorder, right? Okay, 23-year-old woman underwent total thyroidectomy for carcinoma of the thyroid gland. On the second post-operative day, she brings to complain of a tingling sensation in her hands. She appears quite anxious and later complains of muscle cramps. So which of the following is the most appropriate initial management strategy? Anybody? Very good. It is due to hypocalcemia, and we have to give the IV calcium infusion in the treatment for severe symptomatic hypocalcemia. Although there's typically oral calcium supplements, is sufficient in patient with mild symptoms, since post-thyroidectomy hypocalcemia is usually due to transient ischemia of the parathyroid patient and is self-limited in most cases of the problem is resolved in several days. In cases of persistent hypocalcemia, vitamin D preparations may be necessary. There is no role of thyroid hormone over here. Whenever there is a symptom like this, muscle cramp, just after the surgery, that means there will be the calcium level loss because with the thyroid, you already remove the parathyroid gland as well. But few surgeons will do this thing that they just take the do the thyroidectomy and take the parathyroid gland and just place into the hand. So your parathyroid level will be more good. Okay, doctor, I will tell you this thing in the end of the session that which book you have to use for your this thing, and if you just already took the course, so you don't need to just go for any book BCQs. You just have to go to the portal, and there is lots of BCQs regarding surgery, regarding medicines, and MedExpert being so kind, they just put the different folders. They made the flashcards, so it is couple of 10,000, 8,000 BCQs over there. So no need to buy a book yourself because how many books you can buy? They have their RSCGP book for surgery, for gynae, for everything. So we just took the subscription for you guys, and we just making BCQs from the RSCGP that is indicated for the AMC exam, and we made the BCQs, and just we are solving these BCQs right away over here. And we have lots of BCQs on our portal, and those who can take the course can take the access of the portal and enjoy a lot of free BCQs over there. So 65-year-old man has an enterocutaneous fistula originating in the jejunum secondary to inflammatory bowel disease. So which of the following would be most appropriate fluid or replacement of his enteric loss? Anybody? So the answer is C. You need to give the Ringel lactate solution. It's not the 3% Normus line. Bile and fluids found in the duodenum, jejunum, and ileum all have an electrolyte content similar to that of the Ringel lactate. Salivary, gastric, and pancreatic colons have high potassium and low sodium. Pancreatic secretion are high in bicarbonate. It is important to consider these variation in electrolyte pattern when calculating replacement requirement following gastrointestinal loss. This is very important slide. If you want to take a screenshot, you can take it. There's the students who are in the group of WhatsApp, those who buy the subscription, you just get the whole lectures and you will get the charts and everything, right? This is an important question because you need to know that in which area of the colon have the highest concentration of which type of amount of substances like either sodium, either potassium. So it will be easy for you to solve the question. Okay, so 39-year-old man is undergoing resuscitation with blood products for an upper GI. He is suspected to having a hemolytic transfusion reaction. So which of the following is appropriate in the management of this patient? Anybody? It's basically that fluid and mannitol. Why we are giving it? Because hemolytic transfusion reaction lead to hypertension and oliguria. The increased hemoglobin and plasma level will be clearly via the kidney, which lead to hemoglobinuria. Placement of an indwelling catheter with subsequent demonstrating of oliguria and hemoglobinuria not only confirm the diagnosis of hemolytic transfusion reaction, but is useful in monitoring corrective therapy. Treatment begin with discontinuation of the transfusion. That what I said, that whatever the harm any drug causing, first you need to stop that, followed by aggressive fluid resuscitation to support the hypertensive episodes, and then increase output. You need to put three things right away. Steroids we will give on the reactions who is just having a some mild rash and mild having. Although if it is a patient is already going in the state of shock, you need to revert the shock. For reverting the shock, you need to manage the patient from the three ways. First, you need to stop the transfusion so the more harm is not be able. Second, you need to give the aggressive fluid to just take that condition out, that is from the turn from the hypovolemia. Third, what you need to do is patient is oligouric. That is the sign of alarming. You need to increase the urinary output. That's why you are just giving these mannitol and IV fluids. Inducing diuresis through aggressive fluid resuscitation and osmotic diuresis is important to clear the hemolyzed red cell membrane, which can otherwise collect in the glomeruli and causing renal damage. And cleansation of the urine help prevent hemoglobinuria, clumping, and renal damage. Steroids do not have a role in the treatment of hemolytic transfusion reaction. This is very hallmark. That's what I told you in the start. Okay, so 14-35-year-old men with new diagnosis of Crohn's disease present with rapidly enlarging painful ulcer on the lower extremities. Culture of the lesion are negative and skin biopsy reveal no evidence of malignancy. So which of the following is most appropriate treatment options? Anybody? Very good. So this patient is already having Crohn's disease. So what is the having the Crohn's disease means? So this patient developed the condition of pyoderma gangrenosum, which is a rare cause of cutaneous ulceration that can be associated with IBD, right? In this patient, the drug of choice will always be the systemic steroids along with immunosuppressant. Nothing can be prevented when the patient has developed anything from the IBD, like a surgery or something. First, you need to give the steroids. You need to settle down the inflammation. Second, you need to give the immunosuppressant so that condition will be more likely settled down. So that skin condition will be all good. If you are doing any ligation, you are going any surgery, that will causing no benefit but the more harm. Okay, following a weekend of snow mobbling, a 42-year-old man comes to ED with pain, numbness, and discoloration of right foot. You diagnosis for frostbite. So which of the following is proper initial treatment? Anybody?
A.
Very good. The answer is you need to immerse the foot of the patient into the above the body temperature, that is the 40 to 44 centigrade, or we can say the 104 Fahrenheit, right? This is the effective method because frostbite region is numb and especially vulnerable. It should be protected from trauma or excessive heat during the treatment. Further things you need to do is elevation, minimize the edema. You need to administer of antibiotic, tetanus, and debridement of necrotic stain. If you don't do this thing and you are just covering over it or something like that, you're just wasting the time. The first and foremost goal is to immerse the foot of the patient in the water. Okay, 63-year-old man with history of poorly controlled diabetes, present with right leg swelling and pain. Patient denies trauma to leg and report it was normal yesterday. Examination of the right lower extremity is significant for extreme tenderness to palpation, erythema, edema extending up to the knee. X-ray of right leg showed this swelling without gas or osteomyelitis. The patient's vital are normal, started on broad spectrum IV antibiotics and insulin. An hour later, patient's heart rate increased to 125 beats per minute. And erythema has progresses to the thigh with new blister formation on the leg. So which of the following is more appropriate next step in the management? The doctor diagnosed it as a diabetic case and give the insulin. And after giving the insulin, the patient's erythema progresses more. You see the question? And the heart rate increases to 125. Even the broad spectrum is also started. So what is the investigation you will go further? X-ray is already done. Very good. This patient is already developing a necrotizing soft tissue infection. So what you need to do is you need to open the site of the any infective site, and you need to release the air because tachycardia will indicates the sign that you need to go for the immediate surgical intervention. Unless if you are going any type of CT scan or MRI, the patient will lose their foot. Because this for this type of cases, we say we don't need to see the dawn and dusk anything. If you are coming with a 3 a.m. right away, you need to open it till 3 a.m. You just don't wait for the dawn or something like that. You will do in the morning or something. The patient will lose the foot. This is the case of very immediate intervention. So, 65-year-old woman present with a 1 centimeter lesion with a pearly border on her nose. Punch biopsy is consistent with basal cell carcinoma. She is scheduled to undergo Mohs surgery. Which of the following is benefit of Mohs surgery over wide localization? These are the two options. Mohs surgery offer a shorter operating period. Surgery is a smaller cosmetic defect while obtaining negative margins circumferentially. And other options are can be performed on many different type of skin cancers, result in less recurrence and metastasis. Mohs surgery does not depend on the intraoperative evaluation of a specimen margin with frozen section. This and this. These two options and these three options. Okay, let's see the answer. So it is right. Mohs surgery describe a technique for resecting either basal or squamous cell carcinoma on the face or near the eyes or nose in order to achieve the optimal cosmetic result. Right? That's why we always, whenever there's a question regarding it, we always say refer to plastic surgeon because these type of treatment can be only done by the plastic surgeon. They can be asked with a different way. In this question, they ask the Mohs surgery benefit and why we are doing it and what's the purpose of the Mohs surgery. In other question, they will ask you that there's a basal cell carcinoma on nose and what will you do. So in this thing, you need to answer it that you have to refer the patient to the plastic surgeon. These two type of questions they ask repeatedly. Okay, 54-year-old man sees you because of growth on his lower lip. He smokes tobacco, has a fair skin complexion, and work outdoor. The biopsy reports confirm a carcinoma. So, which of the following is the most common diagnosis for tumor involving the lip? Very good. These are the region for the lip. Most commonly, the squamous cell carcinoma is the main tumor that constitutes 15% of malignancies. The lip malignancies present on lower lip will be 88.9%. Basal cell carcinoma can be occur less frequently and affect the upper lip more often the lower lip. Malignant melanoma, keratoconthoma, Voracious carcinoma also present in upper lip, although much less frequently than squamous cell carcinoma. So this is the thing you have to remember it because in the exam either they can ask you this way or either they can give you the picture of a lower lip and they will ask you that what is the diagnosis. So from the symptoms and from the pictorial and from the site of the body part, you need to remember it that which cancer is common on which side. It's an important thing. Okay, so your hospital is conducting an ongoing research study involving the hormonal response to trauma. Blood is drawn regularly with the approval of some board for various studies. So, which of the following values are likely to be seen after a healthy 36-year-old man is hit by a bus and sustain a ruptured spleen and lacerated small bowel? This is a condition where a person can go in a state of shock. So, they're asking that in this state, which hormone will be increased or decreased? These are the four options. The fifth option, okay, there's only the four option. Very good. So it is the increase insulation of increase in secretion of insulin. Though the immediate release of catecholamine causes a transient drop in insulin level, shortly thereafter there is a significant rise in plasma insulin level in injured humans. Because of increased peripheral insulin and resistance and conjugation with increased insulin production, the overall net effect after severe injury is that hyperglycemia. Since injured patients are highly hypermetabolic, it might be expected that the activity of thyroid hormone would be increased following injury. That means you have to remember that the level of thyroxine, level of insulin will be increased whenever there is a patient who is coming after the injury in the RTA. This is you need to remember it because sometimes they'll ask you that which level will be increased and sometimes they ask you which level of the hormone will be decreased. This is not the case, however. This is not the case. However, an increased levels of the thyroid hormones are not seen. Vasopressin is regulated by serum osmolarity. In the post-injury period, many factors are at play that provoke the excretion of vasopressin. Glucagon secretion is normal and increase after injury. Not only is aldosterone levels elevated, but the diurnal fluctuations already seen are lost. So you have to remember that which levels are increasing, which level are decreasing. AMC can ask you either way. Sometimes they ask you the increased level, and most of the time they ask you the increased level, but sometimes they can ask you the decreased level as well. So that's why I just put the explanation of all the hormones regarding which are increasing and which are the decreasing pattern. So, an 18-year-old man was assaulted and sustained significant hair and facial trauma. So, which of the following is the most common initial manifestation of increased ICP? Yes, this is the scam message because those people who cannot do anything by themselves, whatever they do is just to make other things ruin. Because we are MedExpert is the only organization that can provide the free sessions for the BCQs. They have just buy from the RSCGP website or they have just collected the information. They are giving them the free lecture for the students. So the people who are doing this thing by writing something odd, this is a very weird thing because we are trying to help other people to pass the AMC. This is the very kind gesture of MedExpert that is helping the people to pass the AMC. So they are giving you the insight that how the surgical BCQs can be asked. So just ignore this message. We have to concentrate on the BCQs. Okay, so everybody answered the A. Very good. So this is the closed head injury case may result in cerebral contusion owing to depression of the reticular formation of the brainstem. So this type of injury is usually reversible. Characteristics. So the thing is important over here is this is the reversible injury, right? Symptom will be occur initiated by progressive depression of mental state, local bleeding, swelling, produce an increased ICP. Patient may develop cushion triad. This is very important to remember. Hypertension, bradycardia, and irregular perspiration. Sign of a raised ICP. Lateralizing signs like motor or pupillary are relatively uncommon and are highly likely suggestive of an focal intracranial lesions. So, a 28-year-old man is brought to the ER for a severe head injury after a fall. He was intubated in the field for his decreased level of consciousness. He is tachycardic and hypertensive. On examination, he is noted to have an obvious skull fracture and his right pupil is dilated. So, which of the following is most appropriate method for initially reducing his ICP? This question I'm literally telling you coming from the 2022 up till right now regarding the skull fracture. And they will give you with a different presentation, like they will sometimes give you the basal fractures presentation and ask you the will be the management. And sometimes they will give you the normal skull fracture and they will give you the hypertensive and tachycardia. So this question is coming every month from since 2022. Answer is E. Most of the people will answer the C, but it is hyperventilation. Only way you have to do is over there is emergency measures to reduce, we can say, intracranial pressure include hyperventilation, mannitol infusion, and elevation of the head of the bed. That will be the Tenderberg position. However, in the face of inadequate volume resuscitation, osmotic diuresis with mannitol and placement of patient in reverse Tenderberg may exacerbate the patient's hypotension. That's why we are not doing it. The only thing we can reduce is hyperventilation. CT scan should be performed as soon as possible along with neurosurgical evaluation in order to determine the need for operative drainage or decompression. We just see the question and this patient is intubated, right? So you cannot do this in a tenderable position and you cannot over volume the patient with mannitol. So in this condition, the only way to reduce it is to hyperventilate the patient. This is the triad of strategy. But if you are not doing the two things, at least the thing you can do it, you can perform it right away. So a 45-year-old male was an unhelmeted motorcyclist involved in a high-speed collision. He was ejected from motorcycle and was noted to be apneic at the scene. After being intubated, he was brought to the ER where he is noted to have a left pupil dilated that respond only sluggishly. What is the pathophysiology of his dilated pupil? Why his pupil will be dilated? It's B, doctor. It's because of the herniation of the ulnar processes of the temporal lobe that causes in the increase in the pressure tend to displace brain tissue away from the source of the pressure. If the pressure is sufficient, herniation of the uncial process through tentorium cerebri occurs. Pupillary dilation is caused by compression of the ipsilateral motor oculomotor nerve and its parasympathetic fiber. So if the pressure is not relieved, the brainstem will herniate through the foramen magnum and cause death. That's why most of the people die. Hypertension and bradycardia are pre-terminal events. So a patient is brought to the ER after a motor vehicle accident. He is unconscious and has a deep scalp laceration and one dilated pupil. His heart rate is 120 beats per minute, blood pressure is 80 by 40, and respiratory rate is 35 beats per minute. Despite rapid administration of 2 ml normoxidine, the patient's vital signs do not change significantly. So, which of the following is the most appropriate next step in the workup of this hypotension? You will consult neurosurgical department for emergent ventriculectomy to manage his intracranial pressure, or you consult for emergency craniotomy, or you can do the burr hole drainage at the bedside for suspected epidural hematoma, or you do give the mannitol and hyperventilate the patient, or you will do the fast ultrasound. See the question again. One pupil dilated means deep laceration. No need to go for any type of other intervention if it is mentioned regarding the scalp. You have a third option as well, burr hole as and mannitol option other as well. This is a tricky question. Remember it, whenever there is a neurosurgery question, these are always tricky. As I told you that there's two or one question always from the neurosurgery. That one of the skull fracture one and that this is the another one. Okay, so the answer is E. You need to go for the fast. As I told you that you need to see the symptoms as well. Except in rare circumstances, hypotension in a trauma patient should be presumed to be secondary to hypovolemia and not the head injury. When cardiovascular collapse occurs as a result of rising intracranial pressure, it is generally accompanied by hypertension, bradycardia, and respiratory depression, right? On the other hand, loss of consciousness following head trauma should be assumed to be because of intracranial hemorrhage until proven otherwise. So we have to evaluation of head injury patient include assessment for other potential life-threatening injuries, including abdominal, thoracic, pelvic hemorrhage. So in this case, you already done everything CT scan and everything for the head injury. The second survey, you have to go for the abdominal one. If abdominal is still clear, you have to go to the thoracic one. If thoracic is clear, then 100% it will be the pelvic fracture. Appropriate workup should be sent like X-ray fast abdomen or ultrasound fast pelvic X-ray should be sent. Rarely, a patient may be sufficient hemorrhage from a scalp laceration to cause hypotension. But cautious should be used in attributing hypotension, tachycardia, and solely to an injury. Because they already mentioned it is a laceration. When there is no hematoma, when it is no any type of IC bleed, then it should be other causes. So you need to rule out first abdomen, then thoracic, and then pelvic one. Head is already clear, and they say that it is a deep laceration. The second thing you need to clear it down is the abdominal trauma. Okay, so 36-year-old man sustained a gunshot wound to the left buttocks. He is hemodynamically stable. There is no exit wound, and an X-ray of the abdomen shows a bullet to the located in the right lower quadrant. So, which of the following most appropriate in the management of suspected rectal injury? Anybody? Very good. As I told you that if the patient is hemodynamically stable, what you need to do is you need to go for the CT scan to suspect and to see the, because CT scan will be the definitive treatment of choice or investigation of choice. So you need to see the rectal perforation. You need to go for it. And if they say that a patient is hemodynamically unstable, then would be more preferred option will be the ultrasound. But over here, the most preferable option will be the CT scan. And after that, you will go for the ismidoscopy and any type of endoscopy after that. But first, you need to see the thing that where the perforations was happen, where the leakages happen, where is the site of the hemorrhage is occurring, right? So, 62-year-old woman is seen after a 3-day history of fever, abdominal pain, nausea, and anorexia. She has not urinated for 24 hours. She has a history of previous abdominal surgery for inflammatory bowel disease. Her blood pressure is this, and her pulse is 136. Her response to his physiological state include which of the following? Anybody? Very good. So this is in response to hyperkalemia. In any type of surgical procedure, among electrolyte imbalance, always the potassium will be the main lead. Either it will be the hyper, it will be the hyper. The biochemical changes associated with shock result from tissue hypoperfusion, endocrine response to stress, and specific organ systemic failure. During shock, the sympathetic nervous system and adrenal medulla are stimulated to release catecholamines, renin-angiotensin, antidiuretic hormone, adrenocorticotropin, and cortisol level increase. Resultant changes include sodium and water retention and an increase in potassium excretion. Protein catabolism and gluconeogenesis. Potassium levels rise as a result of increased tissue release, anaerobic metabolism, and decreased renal perfusion. If renal function is maintained, potassium excretion is high, and normal plasma potassium are restored. As always make a rule that whenever they are talking about any electrolyte imbalance in a GI surgery, first always think about the potassium. Make a rule. If you correct the potassium, the sodium will be itself is good. So a 20-year-old man present after being punched in the right eye and assaulted to the head on a facial CT scan, he is noted to have a blowout fracture of the right orbital floor. So which of the following findings mandates immediate surgical intervention? Very good. When the patient is not moving the eye, this is the red flag. Blowout or brittle fracture require immediate operative intervention in the Event of extraocular movement entrapment. Inability to move the eye suggests entrapment of the superior rectus muscle and mandates surgical release of the muscle. Patient with blood fracture can have orbital ecchymosis, pain, diplopia. Surgery is indicated in patient with anaphthalmosis greater than 2 millimeter, diplopia on primary or inferior gaze, entrapment of extraocular muscle. What is actually happening over here, right? Or fracture greater than 50% of the orbital floor. So, a 32-year-old man is a high-speed motor vehicle collision and present with an obvious pelvic fracture. On examination, he has a scrotal hematoma and blood at his urethral meatus. So, which of the following is the most appropriate next step in his management? This question is commonly asked regarding the urological surgery. Very good. Whenever there is a blood and meatus and you are suspecting urethral injury, always make a rule that you have to go for a retrograde urethrogram. Always make a rule. You cannot pass a folly because if you pass a folly, you can make more disruption, you can make more injury over there. Or there will be a there's a urethral disruption, a pubic catheter should be placed. Never ever go for the placement of Foley catheter. Most of the people will do this mistake and they put the Foley catheter, and this will cause a more injury. Whenever there is a blood in meatus, whenever they say that they cannot be able to just move their penis, or whenever they just maintain this terminology in the exam, that there is some type of tenderness or bruising on the side of the meatus. This means there's an injury of the penis gland or something. So you never go for the Foley catheter. Either you can go for the retrograde urethrogram or you have to go for the suprapubic catheterization. 22-year-old woman who is 4 months pregnant, present after a motor vehicle collision, complaining of abdominal pain and right leg pain. She has an obvious deformity of her right femur. She is hemodynamically stable. So, which of the following is best next step in the management? Anybody? I need to put one thing over here. She is hemodynamically stable. Very good. So if it is hemodynamically stable, if there will be an option for the CT scan, you will definitely go for the CT scan, but there was not giving over there. Also, the thing is, the only option you have over there is fast ultrasound. MRI is not associated with ionizing radiation, so you are not typically going with the MRI. Also, MRI is more likely for the tissues. You have to see the soft tissues more likely. CTs can give you the wide picture of the any type of trauma, either it is tissue, either it is going in the bones, either it is going regarding the gas or something. But the foremost and for the initial one and in the pregnant patient or something, the more safer will be the ultrasound. So you are going with the fast ultrasound. Okay, so we have a second last question. 26-year-old men complaining of pelvic pain after a motorcycle collision. Physical and radiological examination confirm a pelvic fracture. Urological workup reveal a normal urethrogram and an extraperitoneal bladder injury. So which of the following is the most appropriate treatment for his bladder injury? Anybody? Okay, so the answer is D. The management of bladder injuries is dependent on its location and concomitant injuries. Extraperitoneal bladder injuries can be treated with initial catheter drainage followed by repeated imaging of the healing. Surgical repair for extraperitoneal bladder injuries is indicated at the time of internal fixation of the pelvis to prevent infection of the hardware. If there is a need for operative repair of the rectum or vagina, if exploratory laparotomy is indicated for the reason and there is no an injury to an avulsion of the bladder neck, intraperitoneal bladder injuries are repaired surgically. A suprapubic catheter is not indicated in the setting of a normal erythrogram, but if indicated there is a displaced urethral injury, bilateral nephrostomy tubes are not indicated in the setting of a bladder injury. So this is kind of tricky question. Catheter drainage for 2 weeks followed by repeat imaging, because might be possible that right away the imaging is normal. But if you are going after the 2 weeks, because it's a pelvic fracture, might be there's a compressing effect on that place or that part of the body. So you have to repeat it until your fracture will be stabilized, until your fracture will be good. So that will be, need to take out the catheter. So a 58-year-old man present to the ER after falling 10 feet from a ladder. Examination reveals stable vital sign, no evidence of respiratory distress, multiple right side fracture, chest x-ray show a hemothorax on right side and a tube. The thoracostomy is performed in the ER. Approximately 700 ml of blood is immediately drained with the placement of thoracostomy tube. Over the next 4 hours, he continued to drain 300 ml after the original evacuation. So which of the following is definitive treatment for this patient? Anybody? Now the answer is platelet, FFPs, secondary tube thoracotomy in ER or operating room. 700 ml blood is already out when they place the thoracotomy tube, right? And for the next 4 hours, he is draining 300 ml per hour. So what is the definitive treatment for this patient? These questions are the pet question the AMC will ask. Doctor, when there is a type of hemothorax, so what will be the definitive management? Definitive management is always to put the thoracotomy in operating room. If you are not putting it, the hemothorax will be more and more over there. What's the need of FFP over here? The patient is not going into hypovolemia, but the patient is in hemothorax. For hemothorax, you need to drain it. You need to save the lung, right? The recommended guideline for thoracotomy in patient with a hemothorax are greater than or equal to 1500 ml. Immediate drainage of blood through the thoracotomy tube after placement of greater than 200 ml of continuous drainage of blood for several hours. And this patient already going 300 ml per hour. After the original evacuation, the patient's physiology and blood transfusion requirement should also factor in a decision for operative intervention, but not right away. Right away, the treatment is putting the thoracotomy tube. So with this question, we are just ending our surgical BCQs. For the recall course students, I just welcome you all and we will start up with our surgical, we can say chapters from Sunday onwards, and I'll take the surgical lectures and I'll put lots of BCQs as well regarding the vascular surgery, abdominal surgery and all the portion we will cover it on Sunday as well. And we have lots of BCQs to make you sure that you will pass in your exam in first attempt, or those who just not couldn't make in the first attempt can go for the second attempt. I would like Asma to tell you the further course detail and how to just take the BCQs and how to take the access of the library. Asma will tell you more clearly. Hello, Asma, are you there?
Yes, I'm here, Dr. Nabira. Thank you so much for this informative session. So, for all the students who haven't joined us for the recall crash course, just quickly tell you about the crash course. Is that what we are doing in the crash course is we are discussing the important recall questions and important questions that can really help you to pass the AMC exams. So, all those students who are done with their theory and they want to practice the questions, they want to practice the recalls, all the new recalls or the previous recalls, then the recall crash course is the option for you. And in the recall crash course, you will be getting notes and flashcards that will really help you to cover your theory and revise all the important points. And apart from this, We are going to provide you all the recalls of the 2 years and including the new recalls as well. So if you want to enroll in the recall crash course, or team has shared our numbers in the chat box, you can just inbox us and we are going to help you how you can enroll in the course. And if you need any help regarding the course, we are here for your support. And for those students who don't want to join the course, we provide free guidance as well. So if you need any guidance regarding AMC exam or anything that is bothering you, you can just message us. We are always here for your support. We have free guide group activities on daily basis at 2 p.m. GMT with Dr. Aisha Iftihar in our guide group. So you can join the guide group and participate in the free activities in which we discuss questions on daily basis. So this was all about the course. If you have any questions, if you need any help, we are here for your support. So that's all for today's webinar. Thank you so much, Dr. Nabira, for this valuable session. And all the students, all the best wishes to you. So if you have any question, you can just write in the chat box. We're here for your support. Thank you.
Any question anybody asks about related to the course regarding any BCQs, those who have already joined the course can message me if you have any query, or we will start our surgery lecture as well. You can message the management as well and in the group. So we will facilitate you whatever we can do for you, right? Thank you.